Well, I guess there were early indications to my parents that I might end up being a doctor, as when I was about 8 or 9, they bought me a junior microscope. Here it is. The same one, for Christmas. And I set about making slides of the blood of our Christmas turkey. And actually you can see, and Gillian's blood as well. My daughter said that was really a bit weird, but there we go. So some 10 years later, I became a medical student at St. Bartholomew's Medical School. And looking back, I describe myself as being a middle-of-the-road student. After graduating, I opted to specialize in psychiatry, in part because I was taught psychiatry by an inspirational teacher, Dr. Ruth Seaford, but more about medical education later. I did my junior psychiatry at St. Thomas's, practicing on a ward underneath the portrait of Sir William Sargent. Now, Sargent was a psychiatrist that was known for his evangelical zeal in promoting treatments such as psychosurgery, deep sleep treatment. But he had a hatred, apparently, of anything psychological. He was there, when I was there in the late 1980s, boy, did his legacy live on. My consultant was peculiar in so much he actively discouraged me from talking to patients. But I did learn a lot, however, about drugs and how valuable they are in the treatment of mental disorder. But I also learned something serendipitously about the unconscious mind. My senior registrar could do something very particular, something that I hadn't seen before, and I found it very interesting. He could make sense of what I'm going to call the odd behavior of very ill patients, by which I mean psychotic patients whose mind has drifted out of contact with reality. So let me give you an example. A patient I remember well had a diagnosis of bipolar disorder. So that meant her mood would go high and it would go low. Now, when she was high, she wouldn't be high in a euphoric, happy sense of the word. She would be high in a very irritable sense. And she engaged in relentless criticism of me. I could do nothing right. And she would criticize me in front of the consultant on the ward round. And these attacks upset me. And I used to dread having to go and see her to treat her. But my colleague, we were contemporaries, he shared the other patients on the ward, so he really didn't see her or treat her. He could do nothing wrong. He was praised in front of the consultant. I really didn't understand, but my senior registrar did. He could talk to this patient in a language she could understand, and he could understand her, she could understand him. And gradually the story of her internal world appeared. This woman had a daughter and a son. Her daughter had looked after her, but in her mind, her daughter could do nothing right. Her son, however, was marvellous. In reality, he was in Australia. Now that got me interested in the unconscious mind, and in particular how psychoanalytic thinking can cast light in dark corners of the mind. It also helped me as a doctor because psychoanalytic thinking relieved me of identifying with the projective phenomena of my patient. In other words, the projection of her daughter into me. And it helped me respond to her simply as an ill patient in need of treatment. In other words, I felt much freer to go and see her and treat her. Let me do that, sorry. Now I could understand what was going on. So I came to St. George's as a senior registrar in forensic psychiatry under the mentorship of Professor Nigel Eastman. Here I met Annie and Gill. And so I continued my training via saintly medical schools, St. Bartholomew's, St. Thomas's, St. George's. That's 3 out of the 4. I've just got St. Andrew's left. So forensic psychiatry is the speciality which treats individuals who have a mental disorder, who present a significant risk to the public. Forensic patients, they're also known as mentally disordered offenders, are amongst the most disturbed and complex group of people who require psychiatric treatment. Now, I enjoyed treating these patients, But all too often there was a dearth of treatment options, especially psychotherapy. Forensic patients were deemed unsuitable. They were either too ill, too emotionally disturbed, too aggressive to be treated with psychodynamic psychotherapy. So they were excluded. So after completing forensic psychiatry, I trained in medical psychotherapy here at St. George's. And this training got me interested in two areas. Firstly, I began to work with young people who had a diagnosis of personality disorder, and later on my research would be on that group of patients. The second area was attachment research. Now, attachment theory is concerned with the bonds that we make, the emotional bonds we make between each other as human beings, and the pathological and psychological difficulties that go wrong when these processes go amiss. John Bowlby was really the founding father of attachment theory. So with Pat Hughes, who was my trainer, but many of you at St. George's will know her as our ex-dean of students, and Penny Turton, I was a junior researcher on a research program looking at attachment relationships in the first child born to mothers who'd suffered a stillborn child. Later on, my research was going to look at attachment in violent personality disordered offenders. Now, about this time, I had a stroke of luck. I met Dr. Estella Weldon. And in the early 90s, Estella formalized the new subspeciality of forensic psychotherapy in the NHS. And I had the brilliant fortune to be in on it from the beginning, for which I'm so grateful. So forensic psychotherapy brought together two areas of psychiatry I liked: forensic psychiatry and psychodynamic psychotherapy. And it refers to the application of psychodynamic principles in the treatment and service of forensic patients, whether those people are in secure environments, whether they're in prisons, or whether they're in the community. Tragically, it took several public inquiries which found evidence that some staff had been physically abusive to some patients in high secure hospitals before policymakers realized what forensic psychotherapy could offer. So in other words, there was a wish to shift the culture about this time in the early 90s. And Professor Eastman and Dr. Margaret Orr, who was the medical director of Broadmoor at the time, did a remarkable thing. They saw a creative opportunity to bring together three systems: forensic psychiatry, psychotherapy, and academia in a consultant post. And this was the first consultant forensic psychotherapy post recognized by the Royal College of Psychiatrists. And I got the job. So I found myself as a consultant forensic psychotherapist at Broadmoor and a sort of accidental academic, a senior lecturer at St. George's. But I had the good fortune at Broadmoor to work with a great group of people and work with very ill patients. And I had supervision from Dr. Murray Cox and Leslie Son. And Leslie had one of the most brilliant minds and revolutionized the understanding of the violent behavior in our patients. So just to complete this part of the story, after leaving Broadmoor, I went to work for CNWL, Central Northwest London Foundation Trust, with Annie. Well, she's my boss, actually. And working with two great teams, I deliver and develop psychotherapy services in two women's prisons, HMP Holloway, which sadly is in the process of closing, and HMP Bronzefield. So I've spent most of my professional life being interested in treating people who've done terrible things driven by their unconscious. Unlike my long ago patient who was verbally attacking, the patients I work have attacked with tragic and devastating consequences for others, for society, and for themselves. Now, the offence which precipitates an individual being detained is often the most violent offence, and it's known as the index offence. And this is what I want to spend a little time considering. A fundamental principle of forensic psychotherapy is that the offence has a meaning and that it often contains unconscious elements. It's not just some random tragic event. Freud put it very well. A thing that's not been understood inevitably reappears, like an unlaid ghost. It cannot rest until the mystery has been solved and the spell broken. Blumenthal updated this, that it's characteristic of forensic work that what reappears not in ghostly form, but in action. So the action of the index offence can be thought of as symptom, and forensic psychotherapy is concerned with understanding the meaning behind the action. As Estella Weldon stresses, this is not the same thing as condoning the offence in any way. We need to understand and help our patients understand, because all the research on risk prediction shows that what you've done before is what you're most likely to do again. In other words, future violence is predicted by past violence. Let me give you a medical analogy. Your patient might present feeling symptomatically very tired, and this is with apologies to haematologists everywhere. When you look at their blood film, it might look a bit like that one. There are smaller red blood cells, you can see by the arrows, and our students would know that this indicates a microcytic anemia. And our students would also know there are many causes of microcytic anemia. And as they're such good students, they'll know that one of these is the anemia of chronic disease. As it says in the name, the patient has an underlying inflammatory disease process, such as rheumatoid arthritis. So in a way, I've moved from looking from turkey blood slides to looking at the blood film of the mind. Translating to the forensic, my patient wouldn't say, "Doctor, when I caught my girlfriend and her lover in bed, I felt very angry, jealous, and humiliated." Do you want to think like a forensic psychotherapist and work out his offence? This is the audience participation bit. There's a clue, I've given you a clue in the underlying inflammatory process. What do you think he did? Sorry? Yes, brilliant. Well, do you want to go for the advanced level? Arsoned what? Brilliant. Who said that? Excellent. Bed warehouse. So this man was unaware of his need to burn any knowledge from his mind of the infidelity. It was literally too hot for him to handle. And forensic patients frequently sign up to the axiom that actions really do speak louder than words. They often try to solve internal psychological distress by externalizing the problem in violent action. So I want to rewind a bit from the index offence. Here I am wearing my opera coat, and the title of my talk is a paraphrase of the question Peter Grimes asks in Benjamin Britten's opera. Peter talks to himself and asks, who can turn the skies back and begin again? Essentially, Grimes is asking the question, can one ever undo a moment in one's life? Now, Grimes is a subsistence fisherman whose young apprentice dies in suspicious circumstances while in Peter's care. They'd gone fishing despite warnings of a storm. Although the court had returned a verdict of accidental death, the townsfolk think differently. They know Grimes as a loner, a troubled soul given to fits of rage. So if a moment could be undone, then which moment? Sure, at a concrete level, the moment of the index offence. But to prevent some forms of violence and understand the disease processes underneath the offence, we're interested in constellations of moments. Moments that are suffused with abuse, neglect, violence, and other trauma that are repeated time and time again in the early lives of our patients, especially those who go on to develop a diagnosis of personality disorder. What are personality disorders? Well, I can't do it justice in the time, but essentially they're developmental disorders. They start in adolescence, early life, and they're deeply ingrained, enduring behavioural patterns that manifest themselves as inflexible responses to a broad range of personal and social situations. And they lead to distress in the sufferer and for society in some cases. They affect the way the person thinks, their cognitions, the way they perceive the world. They affect emotions, the range and intensity and appropriateness of feelings. You can suddenly feel incredibly angry if you have particular personality disorders. We call it affective dysregulation. But most of all, they're disorders that affect interpersonal relationships and functioning. Now, why are they important? Well, because they're common, actually. In the community, 10 times more common than people who have a diagnosis of schizophrenia. By the time you get to where Annie, Gill and I work in psychiatric units and prisons, about 60% of people will have a diagnosis of two main personality disorders, antisocial and something called borderline personality disorder. Borderline personality disorder, people are very impulsive, their affect is dysregulated, they have intense fears of being abandoned, they can frequently self-harm. Antisocial personality disorder is characterized by a sort of disregard for the rights of other people, a failure to conform to social norms by hostility and aggression and lack of remorse. As one patient put it, people assume that you make a sort of rational, conscious decision about what you're doing, but it doesn't, it's bang. It's a sudden explosion of violence to me. Now, I need to say very clearly, the majority of people with a diagnosis of personality disorder are never violent. And I'm talking about a small minority of those people. But unfortunately, those people are overrepresented in forensic populations. Now, the villagers knew that Grimes was a troubled soul, given to fits of rage. And George Crabbe, who wrote the poem The Borough, on which Britain based his opera, described Grimes as a man untouched by pity, unstung by remorse, and uncorrected by shame. Not too much of a leap to think that Peter would satisfy diagnostic criteria for antisocial personality disorder, because he also committed some criminal acts. With greedy eye he looked on all he saw. He knew not justice and he laughed at the law. On all he marked he stretched his ready hand. He fished by water and he filched by land. So what causes PD? In brief, they arise out of an interaction between your genes and your environment. And by environment, I mean the social environment, for which in children, their early social world in the main consists of attachment figures, often parents. And it's these early attachment relationships that have gone amiss. Either they've not been formed, or the relationships have been disrupted by neglect, violence, or abuse. When these moments are relentlessly repeated, it takes a toll on the developing mind of the child. But how? What's the mechanism? Well, Peter Fonagy has proposed one such mechanism, that early adversity within attachment relationships inhibits the capacity to mentalize. So what's mentalization? Well, it's minds understanding minds, in brief. And it's a focus on mental states in oneself and others, particularly to explain behavior. So, you know, I think she walked away, the behavior at that point, because she might have been feeling upset or angry or anxious. So it's a process by which we interpret actions in ourselves and others in underlying intentional states. We can all do it. It's a basic human capacity, and it underpins our social and interpersonal relationships, and it shapes our understanding of others. And neuroscience research has now shown that each component of mentalizing, that I won't go through, is linked to specific neural circuits in the brain. So it might be easier to demonstrate. You can all mentalize. Let me show you and give you an example. What would you think if in your hometown you saw a foreign-looking man standing on the corner of an intersection, studying a map, looking up and down the various streets with a questioning expression on his face? Do shout out, except my husband, who just asked more questions when I tried this. You're not allowed to ask more questions. He's lost, yes? He needs help, yes? Good, go on, keep going. How's he feeling? He's got the wrong... You know, you're like my husband, Jonathan. Okay, how's he feeling? Worried, anxious? Sorry, didn't hear. Lonely, yes. Confused. So you see what you've come up with, okay? It's not a right or wrong answer, but you've got a capacity to think of all sorts of different internal states in that person. Okay? So It demonstrates we can take different perspectives. Some explanations are more plausible, and others, some statements are highly mentalizing. I think he's lost. No, sorry, I think he's confused, anxious. Some are less mentalizing if, say, he's got the wrong map. Sorry. Okay, so you've got the general idea that early attachment experience, if you have a caregiver who can think about the mind of the child accurately and understand the child as a thinking and feeling individual, secure attachment develops in the child, and out of that, the child's capacity to mentalize. This has rarely happened for our patients. I can show you that you can all mentalize. Now, when my colleague and I do this exercise with women with borderline personality disorder, some of the responses we hear are, I don't know. He's a perv, he wants to abduct children. So you can see it's the action that gets concentrated on, not the meaning behind the action. I'm grateful for Dr. Colin Campbell's example from a male prison, where a prisoner said, what, a map? Why hasn't he got an iPhone? Now, these responses are not surprising, because there's two main ways in which mentalization connects to mentally disordered offenders. First, Bateman and Fonagy see it as a core pathology to antisocial personality disorder and borderline. But there was very little research data in offending populations, just one or two small studies. Secondly, in Fonagy's developmental model of violence, the capacity to mentalize is thought to be a crucial inhibitory factor for some forms of violence. In other words, if you can think of the other person as a human being, then the normal inhibitory mechanisms and barriers to violence are there. Once you stop thinking of the other person as a person, you can do what you like. So following this through, it means that we thought the moment of maximal violence, i.e. the index offence, there should be a catastrophic failure of mentalisation. And we thought the population that was maybe most pronounced in mentalisation deficits would be those individuals who had the double misfortune to have a diagnosis of PD and committed acts of interpersonal violence. Where else to look but Broadmoor? So if you rate mentalisation on a 0 to 9 scale, you need to be a saint to score 9. We found that in the Broadmoor population, they scored on average 1.74. Now, that's not surprising compared to normal or a psychiatric population, but it was interesting compared to patients who had a PD, a personality disorder, but were non-forensic. So there was something we thought about decreased mentalisation in the violent mind. Here's an example from one of our research studies. You can see it's pretty low mentalisation. These are verbatim quotes, and they're taken from a structured, semi-structured interview called the adult attachment interview, so everybody got the same standardized interview. These people really can't read minds, or they read them inaccurately, seeing slight insults and markers of disrespect too easily. And in women's prisons, I've been struck by how often I hear similar descriptions of the moments preceding violent attacks, not just the index offence, but violence in the prison. Now, you need to know that in prisons, all female staff, whether they're doctors or prison officers, are called Miss. So here's my role play with myself. Well, I don't know what happened, Miss. I hit her. That's it. Anyway, she was bang out of order. Me. Okay, but how are you feeling? I just saw red, Miss. She shouldn't have pushed in front of me like she did. I know it's tricky, but in the heat of the moment. But thinking back now, did you notice anything that triggered you? Well, it's the way she looked at me, Miss. I don't know how to describe it, like I was a piece of shit. So the feelings of shame and humiliation generated are unbearable, and they can't be contained, and they have to be expelled through violence. It's like a reflex arc. If you put your hand on something too hot, the experience short-circuits the mind and is terminated by action. So let me try and illustrate with a response from a research interview. When I went into this flat, I broke into the flat, and there were all this it's quite wealthy sort of people that live there. And when I went in there, there were all these photographs of nice, happy families and all that. I smashed them up, which is why I went in there to nick stuff. I didn't go in there to set a fire. It was just when I see all these photographs and all these effing happy bunny families, and that's why I lit the fire. Now, we don't know what was going on in this man's mind for sure, but one explanation is seeing the happy pictures of families activated his attachment system, but also his previous trauma. And such experiences had left him with a poor capacity to mentalize. This mentalization collapses and you get the behavioral reaction of arson. So we were particularly interested in looking at mentalization on the index offence. And we thought if it's a symptom, then the point at which mentalization collapses is the maximum moment of violence. So if we looked at the capacity of personality disordered offenders to mentalize round the offence, could that predict anything? Could it help us predict how they'll get on in treatment? Can mentalization give us a handle on the unfolding of behaviour in these patients? Because that's what's tricky in terms of predicting which patients are going to make use of treatment and which aren't. So we designed and validated a way of assessing how the index offence was represented in the minds of these patients. And we sort of found it was the case. The patients who described greater levels of interpersonal violence and malevolence in how they were currently thinking about their offence committed the greatest number of incidents across, or more severely aggressive incidents, across the next year in the hospital. Patients who described their victim more respectfully scored higher for pro-social behaviour, so they engaged in more activities and they were more likely to move out of the hospital to a lesser degree of security. So what's all this got to do with medical education? That's the other two legs of my chair. Well, in the final moments, I was just going to highlight one. Here at St George's, we train many healthcare professionals, and we're very good at it. Of those students, about 1,500 are medical students, and on graduation, our new doctors are expected to be able to communicate effectively with stigmatised patient groups. I don't think you could find a more stigmatised patient group than mentally disordered offenders. Now, Britain had considerable empathy with Peter Grimes, but it's hard to feel empathic with people who commit terrible crimes. And over the years, we've got some 400 or so of our graduate medical students have come out to Broadmoor. And this is the sort of thing that they've said. Made me think a great deal about the effects of illness on personality and behaviour, even extremes of violent behaviour. That I find the crimes so distasteful, yet I was able to behold the extraordinary pressures and mental illness that drove them to it. I found the visit very interesting. There's no substitute for first-hand experience for developing, dispelling a few myths. And when we looked at the evaluation, we found that about 76% of those students felt the visit positively altered their perceptions and attitudes. So thanks to all those people that have helped me. Now you may ask, why treat these people? Well, that's a fair enough question. My answer in brief is to prevent future violent moments. Perhaps this patient is correct. I got up and started stamping on his head, and another guy came and dragged him off. I rang an ambulance because I thought he was dead. I went back to the kitchen where he was and I kicked him in the ribs to see if he was dead or not. Now, can you just see how suffused with violence this man's mind is? Asked later in the interview what he'd wish for if he had 3 wishes. I wish I could have a normal life, normal job, normal girlfriend. I wish I could turn the clock back and start afresh. Now, maybe his best chance for a normal life would have been achieved by turning back the skies and beginning again with secure attachment figures. And we can't realise that wish. But although we can't undo the earlier moments, in terms of the legacy in this man's mind might be open to change. And there are now psychotherapy treatments born out of attachment, such as mentalization-based treatment. This is where Peter Fonagy, Anthony Bateman and Jessica Yakeley's work is so important, as they've got a national randomised control trial going. So if this treatment can strengthen these patients' capacity to mentalise, then these individuals might be able to lead more normal lives outside secure institutions, and we as members of society might be more protected. So it's been a particular characteristic of my career that I've been helped and guided by professors whose name begins with P. Peter Songson was my first professor of endocrinology at St Thomas's, Peter Fonagy, Pamela Taylor, and our own Peter McCrory, Pat Hughes and Peter Kopelman. So to all these people, a huge thank you. And there are other professors and people of professorial standing to whom I'm deeply grateful. Professor David Tuckett, Professor Friedemann Fallin, Dr. Estella Wells and Dr. Leslie Son. And thank you to all my friends, colleagues at St George's, Broadmoor and CNWL. Thank you to my parents who gave me a good G times E start and a microscope. And to my family who, in spite of my complete inability to operate a TV remote control, have given me their love and support. In return, however, my career choices have given them countless moments of enjoyment when they've been able to say to new teachers, "I'm sorry, my mum can't get here to parents' evening, she's in prison." Thank you for coming.